Hi, my name is Sandra Samuels, host of Boss Lady Live, where I come to you every Monday night with experts to discuss issues of crime and violence, love and relationships, health and wellness, various different topics that affect us right here in Jamaica. Please like and share and subscribe. Click on the notification bell to be advised when you're on. See you then. Hi, good evening. Welcome again to Boss Lady Live. This is our last session. Can you believe it? Over 60 programs. This is our second season. This is our last program before we end until September. And like every other evening, this is going to be a very informative, interesting evening. And this evening we have, as usual, an expert in our field, Dr. Karen Phillips, and she is a consultant physician and endocrinologist, former HOD Medicine KPH, associate lecturer UWI, and medical director Revamp Rehabilitation Center. Good evening, Karen, Dr. Karen.
Thanks for having me.
Thank you so much for agreeing to being my guest and on such short notice, because I know you are extremely busy. And we at Boss Lady Live like to invite persons who are very au fait with what the subject matter is. We don't want any book knowledge. We want the raw, everyday, in the field, hands-on information. Now, this evening we're talking about hypertension, diabetes, and high cholesterol. Out of the three, I don't want to say I suffer, because I don't really suffer, but I have hypertension, and I do have high cholesterol. I have been on medication for a long time. But during this period of COVID, we hear about comorbid diseases and all of these things, and high risk persons for COVID and all of that. So I thought I would end my series with talking about these very debilitating diseases. Persons can die from them, but they can also be corrected if I'm correct. So hypertension, diabetes, and high cholesterol, these are not contagious diseases. However, they are very serious diseases, and many persons in Jamaica suffer from these diseases. And when I say suffer, I mean suffer, because I even have a client who, he doesn't drive because he has diabetes, and he doesn't have feelings in the bottom of his feet. So he's not allowed to drive by doctor's orders. So this is a very serious matter. So thank you so much for agreeing to talk about these very interesting and what I should say now, important topics. But first of all, before I start, just tell us a little bit about yourself, and why did you even choose medicine? I would like to know who we're speaking to.
Okay, so I'm Karen Phillips, daughter of Olive and Harold Phillips, because that's because my parents to me are the stars.
Right.
I have 4 siblings, so from a big family, a lot of close cousins as well, one of whom you are quite friendly with.
Yes.
Grew up in a big, loving environment. I would want to say when I was a child, I really thought I would go into journalism or law, because I love to chat. My family told me that
But Carol took that from you.
Right. So
yes,
I'm more as an artistic kind of person. But I was at high school in those days. They figure, you go along the science line, on if you have a kind of passion for something, or you go along the arts line if you you're more driven in a particular area. And so that kind of directed my academic course, even though I would want to say in high school, 5th, 6th form, I was still toying with, the arts,
Right.
they have the hard subjects to back up that desire. But anyway, I would want to say that medicine chose me because, as I said, I was like some friends of mine who grew up thinking, well, I want to be a cardiologist or I want to be a doctor. Not necessarily. I hated hospitals. But I think at some point I had this just I don't know, a passion for biology, for human sciences. And so I think that kind of led me along the path when I thought of something that I would do that would naturally make me feel motivated and want to serve,
Right.
That's when I really came to me that, this was medicine. And here we are now. So, the story is told. I tell this story all the time that the first month that I worked as an intern in medicine, I remember, and I think my first rotation was in fact medicine, because we do surgery and obstetrics and gynecology, etc. So in internship, we do the three main areas. And so when I got paid that first month, I thought to myself, oh my gosh, I get paid to do this. I mean, I would do this for free because I got so much joy and passion
Oh,
for
that's great.
it. Right.
Yes.
I tell you, 20 years or so on, I am still feeling the joy and the passion. It motivates me. I get up every day and feel driven and motivated to go to work and see my patients. And
Oh,
I,
that's fantastic. And
I
you
don't
know that when they say when you do what you love, you never work a day in your life.
know, I feel like I
Yes.
don't work, because
Yes.
our family will say, you go to work every day and whatever. And it's just like nothing to me because it doesn't feel like work, really. I'm here
Yes.
what I love. And I think I'm blessed to be doing what I love. So, yeah, here I
That
am.
is so awesome. But they say, medicine and the hospitals and everything in Jamaica is so hard, and they don't have everything. What do you say about that?
We definitely don't have everything. We are developing, I would say,
Right.
especially as it comes to healthcare. We're certainly not where we need to be or want to be, but I would say we have enough. I
Right.
think we have a good, solid training. So I think our foundation has prepared us to deal with what we have to deal with. And I think we have enough. I think there are ways to get around having what we don't have. And I think with the skills that we have, medicine is an art, it's also a science, but a lot of it is an art. And just coming to diagnoses, understanding patients, talking to patients, we are able to do so much. I always tell this story. When I was head of medicine at KPH, I remember that we had some exchange students from a university in Orlando, and they had come down to Jamaica to do what they called tropical diseases. So
Yes.
I was saying to the lead, the head, their supervisor, that, what exactly are you expecting? So I realized quickly that they were thinking that they were going to see all of these infectious diseases, kind of like they think, oh, third world country, these are the kind of problems that they're going to have. And I said to
Mhm.
them, you'd be surprised, but we're having really the same kinds of cardiovascular illnesses that you're having, the same diabetes, hypertension, obesity. We follow that Western trend in terms of our diseases. And so when they came, they were quite shocked because they weren't seeing the malaria and the whatever they
Right.
see. So they were seeing similar cases. And I remember that we were managing some patients with them, so they were observing us managing a diabetic emergency patient. And they were very, flabbergasted because we didn't have much, but we did so much. So
We do a lot with what we have.
right. And so he
Mhm.
said when they were leaving, they said, oh my gosh, you know, you have better outcomes than we do with those kinds of cases. And I said, yes, we do. Because at that time, when I would work out the mortality rate for the year in medicine at KPH, which is seen as underserved and under
Right.
it was coming out at 8%. And when you look at the first world countries, they were coming out at 9 to 10%. So I was like, we're doing something right. So I don't know if it is the type of patients that we have. I don't know. I can't explain it, but
Mhm.
we have enough. That's what I say. We have enough to treat our patients effectively, and we do it. We do it. And there are ways to get around. And don't forget that we now have, we're so blessed. We have JADEP, we have the National Health Fund. Every patient at KPH can access free
Yes.
medication. Like seriously, I mean, even compared to University Hospital, without medications that cost thousands of dollars, chemotherapeutic drugs, that they get for free, So
Absolutely.
I don't think people think about that. They compare.
The truth is not that they don't really compare. They hear people talk, but until people like me or that have the direct experience, because I can remember when I was a friend of mine had breast cancer at the same time. Well, she had it before me. No, we had it around the same time, like very short in terms of time. And some of the things that I was on, I was the one who was actually asking her, are you on it? And she's saying to me, no. And I'm saying, no, go and ask your doctor, what about this? And they put her on it. So, we assume that we are not, some of our doctors are not first world, but they are. And they go to all the different conferences and update themselves and stuff, because a lot of the doctors have successful cases out here,
I mean, I can tell you stories. We've had doctors who, first class in the field, who get ill in the United States and choose to come back to Jamaica to be managed by their own colleagues.
I know one such person too.
So,
yes.
Yeah. So I for people who say that, everybody's allowed an opinion, but just to say from somebody who is in the trenches that we do administer excellent care to our patients and we have excellent results. So,
So let me ask, okay, before I ask you, let us just say good evening to some of our guests. Althea Lawler, yes, welcome. Suzanne Jones, welcome. Norma Williams, welcome. Thanks for joining us tonight. What exactly is an endocrinologist?
All right, so an endocrinologist is a doctor who really studies diseases related to the hormone system in the body. So there are a number of medical illnesses, including diabetes, that really are related to hormones. And so we do all of that, right? So thyroid, pituitary, adrenal. So these glands that produce hormones, any illness is related to those hormones. So on the production of hormones, that's what we do. So it's really and there are a number of conditions that you wouldn't think about that are hormonally based. So, for example, diabetes, that we're talking about today.
All right. So since you mentioned diabetes, let us start with diabetes, because a lot of Jamaicans, some suffer, some manage, some manage it well, but what exactly is diabetes, and what are some of the signs and symptoms, and how does one care for diabetes?
All right. So diabetes, I was talking to a young lady today, 27 years old, came into my clinic, recently diagnosed. And I said, do you know what is wrong with you? And she was like, well, I know something about the sugar. And then she went off on a tangent. I said, but you know why they call it high blood sugar? So she was like, she has really thought about it. So I like to tell persons that we call it high blood sugar for a reason, because sugar is not really supposed to remain in the blood. Sugar is supposed to basically move into the cells of the body where we use it for energy, but to get from the blood. So when you eat food and it's digested and absorbed into the bloodstream, basically this sugar that is there now needs to get into the cells of the body, and insulin, which is a hormone produced by the pancreas, allows the sugar to move from the bloodstream into the cells. So we call it's almost like a lock and key phenomenon. So you open the lock with insulin, right? And then the sugar moves across into the cells, and you close it, right? So there are some persons now, basically, who don't make enough insulin, or who do make insulin, but they don't respond to it. The bodies don't respond to it. And it comes about. So we call it like it's a relative or absolute deficiency in insulin that results in high blood sugar. But why high blood sugar is important is that sweet blood, the high sugar in the blood, it's toxic to the vessel linings. So when it moves around in the blood vessels to the various organs, it damages the vessels. And that is why you'll hear that diabetic patients will get blindness, heart attack, stroke, kidney problems, nerve problems. It's because of that damage to the lining of the blood vessels, because the sugar in the blood makes it toxic, so to speak. Right?
Is it hereditary?
So for type 2 diabetes, which is the majority, so 90%, 9 of every 10 persons with diabetes will have type 2. So type 2 diabetes, yes, which is because of your body's inability to respond well to insulin, is associated with ethnicity. So pretty much there are some non-modifiable factors why you get diabetes, type 2 diabetes. So increasing age, ethnicity, and familial, right? So the ethnicity, so Afro-Caribbean, Latinos, and those kinds of persons, and as well, you know, a family history.
So outside of a family, when I say you get diabetes, is it something that is already, the deficiency is already in the body, and then plus what you eat,
right? So
makes you get diabetes? How does it really work? Right. You have to have the deficiency.
So if you are genetically prone,
right,
so that's history comes in. So a first degree family member with diabetes. So my mother, my father, my sister, my brother who have diabetes, that puts me at risk, right? So we're talking about 80% of those persons with that kind of family history may be at risk, right? So yes, those persons know if they're put into a particular environment. So we know the environment that we're talking about for type 2 diabetes. So they don't exercise, they're sedentary by extension, they have excess weight on. Those persons in particular, and there are other things that will also contribute to that, but they are the kinds of persons who will develop traditionally type 2 diabetes. You have to bear in mind though that there are some, but this is really less than 5% of persons who will take particular drugs like steroids and some other antiretroviral drugs that may increase that risk as well. But your lifestyle is a big, 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 big modifiable risk factor for somebody who is genetically prone to diabetes. So that's something we can do about, and that's something we should do something about, because the whole importance of diabetes lies not just with diabetes, it lies with the fact that diabetes travels with, I was telling this young girl today, that it travels with these group of illnesses that increase your risk of heart disease and stroke. So these diseases, high cholesterol, high blood pressure, underactive thyroid, obesity we spoke about, sleep apnea, high uric acid levels. Some young women will be familiar with polycystic ovary syndrome. All of these, they travel together, and they have at their roots resistance to insulin, and they increase your cardiovascular risk. That means they increase your risk of strokes and heart attacks. And that's why we get all excited about these illnesses and want to do something about them, because we can do something about them. A lot of them are very lifestyle related, and just by changing our lifestyle, we can do so much.
I only just found out about sleep apnea, which is also a part of my daily routine now, because I have the CPAP machine now. Because I would although I was on hypertension medication, my pressure kept on going up and up and up, and just would not correct. I mean, I eventually changed the medication I was on, but then I was diagnosed with sleep apnea, and in going on the CPAP machine, not only did I sleep better, my pressure went normalized, and I also lost a bit of weight.
Right.
Because I was sleeping better, you know. But these are not things, and I would think that I am I don't want to say well read, but kind of in the know. You know, you kind of think you're in the know, but I did not know about sleep apnea.
Right.
Which is one of the programs that I plan to have. I've been trying to get a hold of Dr. Tollery, but another time I'll catch him. But you know, these are some of the things that I wish was discussed maybe in the doctor's office whilst I was going through all of that, because nobody asked me if I slept well or did I snore or that kind of thing.
Yes.
Nobody, I wasn't really asked until now. They could not control the pressure now, so they were asking me all these various things. If I had known about that, that is something maybe that I would have, sought out earlier.
Yeah.
So that's why I like to have these programs that educate the general public, because these are some of the things that we really don't know about, and the connectivity.
The connectivity is
the connectivity of all of these.
About treating my diabetes. Why are you so excited about treating my high blood pressure? I'm not ill, So when you explain to them what the point is, a time of day is when you have these conditions, then they get to understand. They go, oh, and persons they tend to be much more adherent to their management and their medications when they understand it. When they understand them something that they can't relate to,
Exactly. Yes, Althea is asking, can cancer drugs increase your risk of any of these diseases?
So there are certain cancer drugs, definitely, drugs which are used in the treatment armamentarium for cancer that can increase your risk of, say, diabetes, for example. Yes, definitely. Mm-hmm.
Well, I found that I went on these medications after I came off of chemotherapy. I was now diagnosed with these about maybe a year after I did chemotherapy. So I don't know if that was a part of it, but my mother she never really had diabetes. She was always pre-diabetic. So they had her on these pre-tablets, because my history on my mother's side, there's a history of diabetes. She did have high cholesterol as well.
She had pre-diabetes, so that is why we try to shy away from pre-diabetes. Because patients tell me, "Oh, doc, do you have diabetes? I'm borderline," but they don't understand that.
That's what she had told me. That's why I use the word pre, because she said that he wasn't giving her like he didn't want the levels to go up for her to become diabetic, so he gave her to bring it down. Something like that, she said. But I didn't really investigate the matter until really, I had it. Then I started to try to see if I could exercise it away. It didn't budge. So I did have to go on medication, because I was trying not to go on medication. But I still eventually had to, because I tried exercise, change how I eat, come off meat, cut down sugar, do all these things. But still, the levels were still high.
Right. And some people...
more likely I was predisposed.
Yes, definitely. I mean, as I said, with type 2 diabetes, most persons are predisposed. So definitely, you do have persons, especially persons who have on a lot of weight, who just with lifestyle changes can manage to remain off medications. They get cured. I said to them, no, you're not cured. You're just controlled on lifestyle. So you have to maintain the lifestyle. If you slack off, you gotta go back up. And that's why I try not to tell patients about borderline diabetes and all of that, because it's really the same underlying, what we call pathophysiology, the same underlying problem, just at an earlier stage, and it will progress. It can progress, generally progresses. And so, the treatment modalities, especially as it relates to lifestyle, it should definitely be emphasized. I mean, there's studies which show that just with diet and exercise alone, the risk of converting from pre-diabetes to diabetes is significantly reduced, even more so giving you medications to lower it, So it tells about the power of lifestyle.
What are some of the symptoms of diabetes?
Right. So I think everybody will be familiar with the same. I go back to the same girl I was talking to today, and she said, doc, I do a lot of Google search, and so when I went to the clinic and told the doctor I was having blurred vision, I was diagnosing myself. I said, I have diabetes, and he looked at me like, but you're bright, how you know you have diabetes? And she's like, because I know what I'm feeling. I'm thirsty. I'm peeing a lot. I'm having blurred vision. She wasn't losing any weight, but her appetite was decreased. Now, diabetes, most of the times when it's really at a level where you may need insulin, actually lose weight, despite a preserved appetite. So she wasn't like that, but she also had what we call paresthesia but they're like pins and needles in the hands and the feet. Some women just have frequent thrush, yeast infections, and they can't get over it, and they're wondering if something is wrong. Where some persons have wounds that won't heal readily. So these are some of the things, most of the things that you look at, and if you notice them happening over a period of time, you should pay attention to them. A lot of persons say, "Oh, I'm peeing a lot because I'm drinking a lot," but they don't make the correlation. Yes.
Right. So, with diabetes, as I said earlier, one of my clients also, he has very limited sensation in the bottom of his feet. So I hear you can have nerve damage as well.
Nerve damage, and it's so important. Diabetic foot, it's really, really a scourge. I mean, those lower limb amputations, significant morbidity and mortality. Persons end up. I have a patient recently who he used to have his limbs cut off, and it really took his life in the end, because what happens is that you definitely have the numbness at some point. Some persons start out having extra sensitivity, and then they move on to having the numbness. You're not feeling anything. They're wearing shoes that they're not really comfortable. They get cuts and sticks and all sorts of wounds. They don't feel it until it's way gone. And it's such a source of morbidity. It's really a burden sector and the healthcare dollar and everything. I tell you, it's really bad. There's a doctor here who's doing a lot of good work in that regard, Dr. Mark Taylor, where he tries to really preserve the vascular, source to these feet. But it's really something horrible to see. So when you see someone starting off with a numbness in the feet, etc., it's really alert time. You have to be so careful. The foot care, the daily inspection of the feet,
the nail care, making sure not to get any cuts, any bruises.
Some persons, when they're doing the pedis and they go into the taking out, cutting the cuticle and causing all of that. Those are areas that you can really source of infection. And the same athlete's foot, where you'll have the tinea pedis between the toes and so on. So it's really an alert. Your doctor should be looking at your feet every visit. You should be looking at your feet every day. It's very, very important.
Peter Harriot is asking, can you just say a little bit about sleep apnea? What exactly is sleep apnea?
All right. So sleep apnea, what we're talking about is there are periods during your sleep where, pretty much, to put it simplistically, you go into an apneic phase, you stop breathing, right? So what will happen is that there is a reduction in oxygen supply to the brain during that period. And there are a number of causes. It can be because of obstruction in the upper airway system. So you'll find persons who have adenoids or any growth in the retropharyngeal space, or it can be central. It's something starting in the brain. But basically what happens is that you just stop breathing for periods during your sleep, and then you start breathing again, and there's a lot of snoring, So generally one of the ways that we can tell about this is that we ask patients, do you snore a lot at night? Do people have to complain about you snoring, So they...
But we joke about snoring.
Right.
We joke about snoring, not realizing how serious it can be.
Very serious. And sometimes they end up, because the sleep is so disturbed, that they drowsy and falling asleep, driving and doing all sorts of things. So it's the importance of sleep apnea, again, it's not just because, persons snore, right? And some persons stop breathing for a while, but nothing happens. So what's the big deal? But the big deal is also that it increases your cardiovascular risk. It increases the risk of heart attack and strokes. Yeah.
Because the lack of oxygen, I didn't realize that the oxygen was so diminished also. Because I was having several episodes per night. And the thing is, you get up in the morning tired, so you really don't get a good sleep. You don't get a deep sleep. And when you don't get a deep sleep, then you go through the day, you're tired and you continue. So the body never really goes into a rest state. So that is what really happens. Peter, it's not the best thing. And people say they say you can't sleep off. You can sleep off.
Can't sleep off.
In a nutshell.
End up getting abnormal heart rhythms. I remember we had a young man who had a stroke recently in his 30s, obese. When we did it, because when you have a stroke, we do some tests to see, what is the source. If there's a clot in your heart, or if there's some abnormal rhythm when you're, at times during the day or night. And we did what we call a Holter test on him, which is a 24-hour ECG test on him. And I remember the doctor, the cardiologist, called me and he said, "Boy, Karen, did you see this guy's Holter results?" I was like, "No." And he's like, "Look at it. He's going Brady." So Brady is what we call like his heart rate at times, like early on in coming towards morning, would go down to like 30s, 20s, like in a pattern. So it's like, wow. At night, we need to do a sleep test study on him. When we did a sleep study, lo and behold, at that time of morning was when he was going into his snoring and carrying on with all of that. And that was coinciding with the abnormal heart rhythm. So, we had to sort him out, get him to get, the sleep machine and CPAP machine, etc. But yeah. So it's very, very important. You snore a lot, don't take it lightly, right?
Right. So and Peter, it helped to bring down my hypertension. It brought it down quite a bit. As a matter of fact, I was telling Doc the other day that my levels have not been this normal in a long time, in many, 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 many years. So it really does help, All right. So that is diabetes. We can come back to it. So the next thing we want to talk about high cholesterol. People say, there are various different discussions about high cholesterol. People say eggs give you high cholesterol. Some say no. Some say it's the yellow in the egg. Some say no. Some say if you drink a lot of milk and cheese and butter and in the breads and the rice and all these things. What exactly is high cholesterol and how can we also manage that?
First of all, we need to understand there are different fractions when we talk about high cholesterol. So
you have high cholesterol and you have what? HLB.
We have high density.
LDH.
We have LDH. So to simplify it, we have good cholesterol and we have bad cholesterol.
Right.
So the cholesterol is the LDL or your non-HDL cholesterol. So we have some things called lipoprotein A. You don't need to get into all of that, but just there's some bad cholesterol and there's some good cholesterol, HDL. So basically, the bad cholesterol really goes and it's deposited in the vessels of the body. The whole point of high cholesterol is that it causes atherosclerosis or hardening of the arteries. It really mugs up your arteries, just like a dirty pipe. With all, you ever look in a dirty pipe and say all of that?
Yes, man, and yes.
And say all of that. So all of that goes on in your vessels is really because of high cholesterol, platelets, we call the plaque, right? So it's a whole story behind how that is formed, but basically all of that gets deposited in the blood vessels and occludes the blood vessels, can cause heart attacks, strokes, etc., etc., etc. And so that is the whole importance of high cholesterol. So we know that basically the bad cholesterol will carry fat from the liver to deposit in the vessels and the organs, and the good cholesterol will take it from there and take it back to the liver, right? So it cleans up the vessels. So that's why we call it the good cholesterol. What's interesting about cholesterol is though that the majority of cholesterol, about 80% of cholesterol is really manufactured in the body, right? So it's just about 20% or so that you're getting from your diet. So there are persons who will tell me, "But doc, I don't eat no fat. Everything is low fat and I don't eat this and I don't." I was like, there are some persons you may not, but you may have familial causes, you may have familial problems with handling cholesterol, and that has nothing to do with your diet. However, your diet can contribute to it. So definitely what you can do in terms of tightening that part, you need to do. And so, yes, we basically say to patients, think low fat, right? So you should be reading a label, buy things that say low fat, unsaturated fats. Those are the good fats, right? The fats that say trans fats, that's bad, hydrogenated fats. That's bad, right? So you want to really stay with like the vegetable oils, you know, the canola oil or the olive oil or soy or those kinds of oils. And certainly you want to, you spoke about egg yolk. Yes, that contains more of the cholesterol. So we would usually say egg white, right? So the sources that we send, the guidance really says no egg yolk. I know there's a lot of story surrounding cholesterol in recent times. You know, persons have been saying, you know, we used to say, oh, what was bad is no good. So, you know, people are talking about coconut oil is no good. We still need to understand that coconut oil is still a saturated source of fat. So yes, you know, there are beneficial effects, but you have to be careful about how you consume saturated fats, right?
Okay.
Not in excess. It will contribute to your atherosclerosis or hardening of the arteries. So you have to be careful with that. So I mean, when it comes to cholesterol,
So let me understand you, doc. You're okay. So you're saying the majority of the cholesterol is pretty much how the food is processed,
no, the
because you
majority,
said it's really inside your body already, not really the food that you eat.
yeah,
So I'm not sure if I understand that
right.
exactly.
So
So is that what? So that do you mean that it's hereditary? You're born that way, or exactly what causes the majority of the high cholesterol?
right. So the majority of the high cholesterol is related to what happens inside of your body. And that can be for a number of reasons. It can be medications that you're taking. It can be a family history. So you may have a familial predisposition to that. It can be other illnesses that affect how cholesterol is handled in the body, etc. So
Mm-hmm.
when we say the majority of it is happening internally, so it's just about 20% that is really you're getting from your diet in terms of high cholesterol.
Get you.
Still would
Get you.
want to modify that.
Get you. Peter is asking, could you explain how diabetes and high cholesterol usually pair together and why?
Right. So what happens with diabetes is that diabetes can affect, there is an enzyme which causes a breakdown of certain cholesterol forms in your body. So it affects that. So lipoprotein lipase, it may not mean anything to you, but basically diabetes can affect that. And so you definitely end up with more in terms of triglycerides, and you end up with a problem with your HDL, which is not high enough as you would want. So we call it a diabetic lipid profile, where your good cholesterol is low and your triglycerides are high and your LDL may be high as well.
Okay. Well, I hope that helped you, Peter. If it didn't, let me know. All right. So hypertension now. So hypertension now is another one of the three. So hypertension is caused by what? What are the signs and symptoms of hypertension as well?
So again, you know, we spoke about, we could call it the dangerous octet. So those 8 conditions I mentioned. So hypertension, as you know, is one of them. So like 40% of patients with diabetes will have hypertension, right? So they tend to coexist, right? Hypertension really is a numerical definition. Basically, we know that optimal blood pressure is about 120/80. And so different guidelines will determine a particular cutoff beyond which they will say you have hypertension. And it's kind of fluid, you know, but we're kind of to and fro in the medical community right now with what are the real targets and what are the cutoffs, you know. But generally, to say that optimal blood pressure is about 120/80. Pre-hypertension, we would say anything from 130 to 139, and anything from say 80 to 89. And then hypertension definitely. So stage 1 would be definitely over 140/90. Right? So it's very important to know those numbers. We also talk about hypertension in terms of grade, so severity. So persons who have blood pressure numbers over, say, a lower number or diastolic of over, say, 100, we're going into another ballpark, and a top number of over 150 to 160 going into another ballpark. And so there are a lot of little other isms with it in terms of your age and how tight we're going to go, etc. What you need to know is that the most common cause of hypertension really is primary hypertension, what we usually call essential hypertension. So this is the one that runs in families, right? And there really are no symptoms of hypertension, as everybody, I think, is commonly called the silent killer. Because by the time you recognize that you have hypertension, you may end up with some target organ damage like a stroke or a heart attack or a kidney failure. So it's very important that you see a doctor regularly, especially when you're over 40. Certainly persons who are less than 40, with the whole westernization of our culture, are now turning up more with primary or essential hypertension. But a lot of them, well, it's not a lot, but some of them will have secondary causes of hypertension. What we call secondary causes would mean other conditions, other medical conditions that result in high blood pressure. So a lot of these are hormonal problems like thyroid problems, adrenal problems, etc., etc., etc.
Why does salt affect hypertension?
Right. So salt is thought to increase blood pressure in persons who are excessively, say, for example, in our Black population, we tend to be very salt sensitive. And so salt will increase your blood pressure through fluid retention and those means. So salt is thought to be something that, especially if you are prone to hypertension, that you have high blood pressure, significantly high blood pressure, that you should reduce.
Because when you consume a lot of salt, you also retain water as well. That has a lot to do with the whole hypertension, or should I say, in your body, the state of your body.
Yes. Mm-hmm.
Okay. Wow. So hypertension now causes or can cause strokes.
Right. So hypertension is the number one cause of stroke. Right. So you think about stroke, you think about hypertension, definitely you want to keep your numbers well controlled.
Mm-hmm. And how can you do that?
Well, again, we go right back to
same as the diabetes and high cholesterol.
We're going to talk about your diet. You're going to talk about your sodium content in your diet as well. You're going to talk about, all of the lots of fruits and vegetables. It's a healthy lifestyle. We also know that weight also contributes to your high blood pressure. And so losing weight will also bring your blood pressure down quite significantly. So there are things that you can do in terms of your diet, in terms of your exercise, that definitely will keep your numbers down.
So that's pretty much for all three. I've heard similarities. That, exercise, eating lots of healthy fruits and vegetables. Well, certainly for hypertension, you cut down or cut out the salt if you can, because really and truly the salt, the food without the salt is really. But if you have it issues,
diet, you can use garlic and lemon juice and herbs
to kind of spice up the food. Yeah. Versus using salt.
Yeah. So, and you try to stay away from seasonings, which will having a lot of salt, or sauces like soy sauce. There was a kind of looking at that, just how the content of sodium or salt in the soy sauce, which would exacerbate or increase, blood pressure levels in persons.
Yes. So hypertension also is hereditary.
Hypertension also, definitely primary hypertension or essential hypertension, certainly runs families.
All right, I have seen where young kids, even babies, young children can have the type 2 diabetes. Can young children also have hypertension?
Well, I would say that young children would not have type 2 diabetes, but you may have like teenagers.
Which is the one that they can born with. Is there a diabetes that they can born with?
That's neonatal diabetes, but that usually is by the 6 months of age. But then could be type 1 diabetes.
Okay. Oh, type 1.
But type
Okay. Okay.
1 big people, adults usually get. But now we're seeing a lot more type 2 in the young. But in the young, usually meaning like 12 and up. And maybe younger, you have issues with obesity. The whole type 2 diabetes in young people is linked with increased obesity rates. You know, the
Okay.
fast food culture, the supersizing culture, the sedentary culture on your phone or on your, device, so that, yes, that's a problem. Hypertension, yes, we can have hypertension in young children, but usually hypertension in young children would be from a secondary cause. It would be like from kidney disease or
Get
some
you.
hormonal problem.
Get you. Get you. Get you. Get you. Get you. Get you. The in this whole COVID-19 scenario, you hear about these comorbid diseases, or you hear the word comorbid. I don't know if half the people know what comorbid is. What exactly does that mean exactly? And why does COVID-19 present a threat to persons with hypertension, diabetes, and high cholesterol, and what else for that matter?
All right. So comorbidity or comorbid conditions refer to underlying conditions, or underlying
Okay.
medical conditions, and usually chronic medical conditions, such as what we're talking about, chronic non-communicable illnesses, like what we're talking about. COVID-19, as I said, persons came into the whole arena bursting out like a respiratory phenomenon, and oh, it's just a pneumonia. And even us in the medical profession initially thought that that is what it was. But more and more, COVID-19 is turning out to be really a vascular problem. Like, it's something that really, a lot of its issues are related to how it affects you on a vascular level. And so I point out that effect of COVID-19 because that is what will in particular make persons who have non-communicable illnesses like diabetes and hypertension have a problem, because it may increase their risk of stroke. It may
Yes.
risk of heart attack because of that same clotting vascular kind of effect that COVID-19 is turning out to have because of its inflammation that's affecting the blood vessels. And so we're learning more and more. We're seeing more and more where persons who had COVID-19, I said prior to this spike, I was saying to persons that we're not seeing so much of the acute COVID cases anymore. What we're seeing are persons who had COVID several months ago are now coming with a stroke, with a heart attack, with kidney failure, with the clots in the legs or the lungs. We are seeing the effects of COVID. And so COVID
Yes,
is really,
I've been hearing that too.
yeah, it's really a monster. It's a monster. And so we just really, when you have these underlying illnesses, you really have to do your best to take care, to make sure you maintain your numbers, you maintain your all that you need to keep tight,
Yes.
and it's unfortunate because a lot of these persons are the same persons who are going to say to you, oh, doc, I'm been out of medication because really and truly afraid to come out of my house because of the COVID, and you'll have persons ending up coming to hospital in emergency state. So I have young diabetics at KPH who end up in hospital in a severe diabetic emergency because mom didn't want to take them out to get the medication because they're afraid of COVID. So it just goes to show you, we really have to try and think, not just blinders when we're trying to deal with what is happening now and persons who have chronic illnesses. It's very, very important that you continue your medication. Don't run out. You
Right.
maintain your monitor your blood pressure, monitor your blood sugars, see a doctor regularly, even if it's a virtual visit. There are more options for that now. But definitely, not ignoring your illness is not an option, because COVID definitely will take advantage of those persons.
In terms of now taking the vaccine, persons with any of these illnesses, is there any kind of issue with taking the vaccine if you have hypertension, diabetes, or high cholesterol?
So I tell you, if I could get paid for every time I've gotten that question in the last few months, I'd be a millionaire. You know, up to today, I had this lady called me, oh, doc, I'm one of your patients from 12 years ago, and I want to know. Right. So everybody wants to know. And she wanted to know if she should get the Johnson & Johnson because she heard that one doesn't affect her much, you know, and she had a clot sometime before. And what I say to people is that everybody should be vaccinated. I also say to persons that with everything in life, there is balance. You must weigh your risks and your benefits. I can't necessarily do it for you, but your doctor can guide you, right? So
Yes.
I can say, these are the risks of COVID. These are the risks that we know of from the vaccine. And when you look at the risk benefit profile, it really is in favor of taking that vaccine. So I say to my patients, go get your vaccine. The only person I will say to hold off is somebody who is having an acute issue, say with a clotting problem or something like that. But generally, I say once you're well enough, go and get your vaccine. Because I think definitely if you're taking your chances, and I guess I can speak to this from working on COVID wards. The first month I worked in a COVID ward, I said to myself, I would rather take my risk with the vaccine than with COVID. Because
Right.
those days we didn't even appreciate long COVID. We didn't even appreciate all of these complications post-COVID. There's crazy things happening with patients who've had COVID, and patients with severe anxiety issues, patients who tell the doc, I've not slept a night since COVID. They can't sleep, they're anxiety, they wake up in the night scared, remembering, just scarred from what happened in hospital
Mhm.
and persons dying, and they're not understanding, and they're thinking that I am next.
Right.
Persons with all sorts of complications, you know. So it's not like you have COVID and then you're good. No, you have
Right.
people are having sequelae that going on for months and months. So, you know, I said to people, I'm double vaccinated and I'm blessed and I'm glad. You know, I didn't have
Right.
the way of side effects. The side effects I had, I could ignore, you know. Yeah.
Mm-hmm.
So I think if we are privileged to get the vaccine, if we're getting more vaccines in August, I would strongly recommend young people, old people, everybody, you know.
Get the vaccine. Sherry is asking, does the deterioration of your kidneys cause hypertension?
So, you know, we talk about hypertension and the kidney as a kind of chicken and egg kind of situation, which comes first, because certainly high blood pressure, long standing high blood pressure can damage the kidneys and cause kidney failure. But kidney problems, which may result from other illnesses, just chronic inflammation and other states, will result in hypertension. So it can go either way, yes.
Okay. All right. Um, adults who have hypertension, diabetes, high cholesterol, and they have children, should they be having a conversation with their children? Because I don't think many persons tend to have that conversation with their children, because certainly my mother didn't have it with me. So if that is the case, I'm sure not many persons, since some of these are, some are all, have some kind of um um because again,
Familial predisposition.
predisposition from the parent to the child. Shouldn't parents be having this conversation with the children? And at what stage should
Yes.
they have that conversation? Not to mention what they cook at home.
You see, the sad thing about it, Sandra, which is why I applaud you for this initiative, this program. As I said to Dr. Boyd when she told me yesterday, I didn't know the program, but I was very willing to share, because a lot
Yes,
of people don't know. They do not know to share. So to know,
yes,
to share, you have to have this knowledge base.
right,
People just do not know. A lot of adults do not know. They don't know. They come to me every day. They don't know. And thank God for Google. Even though I try to, you know, caution persons that It's not everything you see on Google which you can take for gospel, because there are some
Right.
unregulated sources. However, there's some good basic sites, CDC, etc., that you can go on and get general good information. And so more and more persons are doing that now, which is a good thing. Because in the past, persons that come to the doctor, they don't ask a question, They come to the doctor, yes, doc. They just want to say something. Then when
Right.
they don't know, they don't understand. You say to them, do you understand what I just said? What again, doc? Seriously, they don't really want to.
Yes.
Yes, I must take this, doc. They're not really there. And even persons who are more educated, they're not really, a lot of them don't think like that. So yes, in an ideal world it would be great, but where that doesn't exist, I think we need to depend on other sources, and like what you're doing is excellent, other avenues where we can pursue this kind of information, and get it out to the persons affected and persons at risk is very, very important. That is why support groups are important. I know you had lupus on here the other day. They have the Lupus Foundation, diabetes. We do have a number of support groups. I run a support group at KPH, and the Diabetes Association. Certainly is a whole encyclopedia of knowledge for that. There are other illnesses.
How does one become a part of that support group?
Which one? Mm-hmm.
You said you have one at KPH, diabetes support group.
It's for my junior diabetics. I call them my type 1, my young diabetics. So as long as you're a patient at KPH, you're a part of that group.
Okay.
Right. So, but there are other support groups, Dr. Tollereed, Professor Tollereed, Marshall, he also is involved with another diabetic support group. So there are a number of support groups, stroke, there's no foundation, a support group related to that. So it's really to get the information out so persons can tap into it and understand what is happening to them and, advise their families. Yeah.
All right. So if a parent is out there listening now, and they are either have hypertension, diabetes, high cholesterol, or all, at what stage should they be looking to say, apart from, of course, learning to cook different in the household, at what first of all, can we get our children checked? And if so, at what age should we say, okay, let us see if our children are predisposed? Because sometimes I see some children who are like very heavy set, and the parent, I know as a fact, is diabetic, but I am sure that that child is not even taken in to the doctor to even check to see if they're having cholesterol issues, diabetes issues, hypertension issues. And I mean, they are now going into adulthood, which is when now they are really going to be, be faced with these lifestyle diseases.
Right.
At what stage would you say to a parent?
I would say to every parent that you should have a relationship with, if not a pediatrician, certainly, so maybe not a private pediatrician, certainly a healthcare facility that deals with children and adolescents. Really. So you know what kind of guides us in that direction is the vaccination. So even yesterday I was talking to Dr. Boyd and I say, oh my gosh, I think I've been a terrible parent because maybe I need to take 3 or 4 shots. No, she said, no, you're all right. You're trying. But so you use that as a guide, right? So
right.
shots, your doctors would usually do basic checks and pick up certain things. And you should really continue to see a doctor regularly. Now, I know that between 5 and 11, you may have a gap in terms of vaccinations, but that is the time that maybe you will have to look out to see if you're seeing any changes in your child, which may not be normal. Say, for example, children who continue to wet the bed, beyond, say, 5, 6, you may want to say, certainly beyond 8, you should maybe perhaps get them checked because a lot of those children, that could be a sign of diabetes. So you have to look out. If the child is putting on an excessive amount of weight, certainly that is not normal, at that age. So you may want to take them in for a check at that point. So it depends on the clues that you're going to pick up. It's not, you don't routinely screen children for these conditions unless you really have a reason to. But you would have to maybe be vigilant to look out for some of the signs that could clue you in that something is going on with this child. This child is drinking more often than not, peeing a lot. You know, this sounds like unusual, you know, or as I said, hypertension usually doesn't present as a primary problem in children, but maybe the child who is failing to thrive, not growing adequately, poorly, not eating well, skin look funny. You may want to take them in for a checkup. They could maybe have some underlying kidney problem. So definitely we do have the resources in place to get our children checked, whether through private or public means, and we just need to utilize them. So there's no magic age. It's really to watch a child as a child grows and notice anything that is off, which doesn't seem quite so right, you know, and
Right.
rely on sources. Sometimes I've had patients come to me saying it's their nurse at school who picked up that they were drowsier than usual, not behaving quite normal. I had a 12-year-old the other day. She was diagnosed with diabetes. It's her school teacher, her nurse and school teacher, who found out that something wasn't quite so right and told mommy. And she,
Right. So let's say before I am pregnant, or I am somebody who has these lifestyle diseases. When I start giving my child, my baby, food, is sugar one of those things like sugar and reduce salt and all of these things we should,
you
you
mean
know,
pregnant
so
or
that the child don't develop a taste bud for the sugar and the salt.
um
I mean, some of these things because since it's sometimes hereditary. Are these some of the things that we should be looking to do for our children
what I would want
when they are born?
so not quite like that, but I would say that every woman should plan pregnancy.
Right.
Certainly you are diabetic or hypertensive or have any of those chronic illnesses, you need to make sure you plan your pregnancy. And if, say, for example, your sugar is uncontrolled or your pressure is uncontrolled, you may want to delay pregnancy. You want to get those numbers right. You want to make sure you're on the right types of drugs, which are safe in pregnancy before you go into pregnancy. During pregnancy, again, you manage your lifestyle. You try not to put on too much weight. That, again, can be bad for the pregnancy and for the fetus. So you really want to manage those things during pregnancy. After pregnancy, it continues. So it's not as if you eat less
There's
sugar.
certain things also as what gestational diabetes or something like that where they develop diabetes during pregnancy as well, right?
You can develop, yeah, persons can develop gestational diabetes, a different type of diabetes. It's really related to the interplay of hormones that become exacerbated during pregnancy. So yes, that's why they
Does
do this.
that go away after you have the baby or is it it continues?
Gestational diabetes generally goes away after you have the baby, but then you have some persons who are prone to diabetes who develop gestational diabetes, and you would have to monitor them at the 6 week visit to see the sugar is okay, and then you have to monitor them annually thereafter because a number of those patients will go on to develop type 2 diabetes later on. Especially
Oh,
who are big babies, they're at risk of developing diabetes later on. So
okay.
so certainly when it comes to the baby now and the children, it's the same healthy messages we're sending out, in terms of reducing the sweets, the refined sugars, more stuff. So a lot of the stuff that we're giving our children, in terms of some of the chips, which have a lot of hydrogenated oils, which are not good for them,
And a whole heap of salt.
the sweet juices, the bag juice, the Pepsis, the sweet drinks, biscuit and bun and cakes and all of that. We try to limit it. Of course, we're not saying that a child can't have any of these, but we definitely try to limit it because we recognize this whole association as you grow older, there are issues like that that can develop in your children.
We have two questions. So Peter says, Doc just mentioned inflammation. What would cause it, and is there a way to reduce or prevent it? I suppose inflammation in terms of I don't remember where we were at that time. Was it the kidneys we were talking about? Was it the kidneys we were talking about?
Not so sure.
What were we talking about, Peter? I can't remember. The inflammation in the body. I think we were talking about I remember you speaking on inflammation.
Well, I spoke of inflammation plays a big part in everything that we're talking about.
Right.
I think the inflammation he was talking about was maybe related to COVID, and I'm not sure. I'm not sure. I'm not remembering.
I'm not sure. Maybe
And,
Peter, you can, oh, he said was just general inflammation in the body he was talking about.
I, general inflammation in the body
Inflammation will be caused by
caused by either an infection or some kind of other illness that can upset your immune system. Right, so I'm not so sure if we're talking about inflammation from COVID, it would be because of the effects of COVID on the immune system, which causes that.
in general.
Yeah.
Sharon says, in terms of diet and lifestyle changes, any tips on how to achieve significant weight loss in a short period of time? And will the weight loss cure or cause these illnesses to go away permanently?
All right. So, the story about weight loss is a very interesting story because it really fascinates me because I realize that, there are myriad diets, a lot of diets, right? Most of the diets will basically say, you should reduce the carbs, etc. Some of the diets, like the Atkins, would say, okay, you reduce, say, for example, it's a low carb diet. Then you have the keto diet, which is saying is a high fat diet. Then you have the intermittent fasting. Now, I would want to say that diets by themselves, they work for a short period, but your body is such an amazing organ that it picks up when you're gone from your set point, and it always wants to get back to its set point. So when you go on a diet and you artificially lower your caloric intake, which is not sustainable, after you lose the weight, and then your body does a thing like this. It just sends out this hormone called ghrelin, and it just say, you're going to get hungry. You're going to want to eat.
Tell about it.
Right back to your set point. And it's really fascinating how these hormones work. There must be a God. So I would say to persons, the best diet is a diet where you just eat healthily. There's a diet called the Mediterranean diet, which is a good diet. It's really plant-based. It says you must eat lots of fruits and vegetables, lean meats, and regulate your carbohydrates. The carbohydrates should be more complex carbohydrates. Limit your sugar in your beverages, etc. And that, I think, is the basis of every good diet. And when you eat like that, it is sustainable. It can be sustainable because you're really just modifying the amounts of what you're eating, etc. I mean, persons are talking about intermittent fasting, which has significant benefits if you can eat like that. In terms of maybe sustainability of weight loss, maybe it is one of those that will, if you can stick to the particular eating and fasting schedule, may result in sustained weight loss. Yes, when you lose the weight, you will definitely improve your chances of not developing these illnesses, or if you have them, improve your outcome. But again, it's only as lasting as long as you maintain your weight, right? So you have to maintain your weight. It's like the other day I was listening to a lady who was doing cosmetic surgeries, and she was like, guys, you can come and you can do this, and for 6 months you will have these, this beautiful effect. However, the weight will come back if you don't maintain it.
Right.
That's what a lot of persons are afraid
What
of.
about water intake?
Oh, you should be drinking lots of water, as much water as you can. So I would say to persons, for your cold beverages or your room temperature beverages, try to acquire the taste for water. It's good for you. It's good for your skin. It's good for your organs. You feel better when you drink water. And so you should try to be drinking as much as possible. Some persons will say, oh, drink 8 glasses. I've seen people going around with big bottles. I saw my young lady working with me today. She was going around with a 5-liter bottle. I was like, no, that's too much water. There's something called water. But definitely water is good.
So any of, can you, will you say that all of these diseases, would you use the word, can they be cured or just managed?
Manage. I mean, I really feel sad to tell my patients sometimes because, I have a 12-year-old girl who is severely depressed. I mean, she's diabetic and she just cannot come to really accept the fact that for the rest of her little life, she's now 12, she's going to be sticking herself every day for the rest of her life. Um, Unfortunately, well, she has type 1 diabetes, but for the chronic non-communicable illnesses, type 2 diabetes, hypertension, there really is no cure. And so, yes, patients who say, "Doctor, means I've got to take it every day for the rest of my life." Yes, you have to take it every day for the rest of your life. Sometimes I
Even if, because people are of the view, and persons who are like vegans and persons who have that healthy lifestyle, they go to the gym all the time, people are of the view that with a total vegan diet, taking out meat, because that's the most popular common one I hear. If you take meat out of, and meat and cheese and eggs and those things out of your body, you can literally reverse. Is there any truth to that?
I don't want to lick the vegan community anyway, but what I would want to say is that certainly you can manage your chronic illnesses like diabetes and hypertension through lifestyle changes, which include diet and exercise. The vegan diet through weight loss can cause sufficient weight loss to maintain you off medications if you maintain it. But then there are other things to consider. Remember, if you're on a vegan diet, you need to make sure you're getting enough of the other minerals and so on that you're not going to get through your diet, like B12, etc. So there are other things to look at, especially if you're going to be strict vegan. But I wouldn't want to knock it. I would say definitely persons do lose a lot of weight on these types of diet, and through the weight loss this can be beneficial, but
Okay.
not that the disease is cured or reversed, it's just controlled.
Okay, Doc. So as we wrap up, is there anything that we have not covered that you would like to say to us? Any kind of advice, any kind of other things that we should look out for before we wrap? And how can we find you? How can we become a part of any one of these groups, these support groups, stuff like
A lot of questions, but I will start off by saying that we have a lot of power in our hands as individuals, and we need to recognize that. We need to understand and appreciate that self-care through just healthy living, right? Just healthy living, and healthy living meaning diet, exercise, lifestyle things, relaxation techniques, whatever things to, because we haven't spoken about stress, which
that?
is
Right.
becoming a chronic issue as well. So there are all these things that we need to address in our life, in our lifestyles, in our emotional space. We need to control all of these things, and we can start out by trying to form habits, good habits. They say it takes 21 days to form a habit. Form good habits. We have a lot of information now. There is almost information overload. We can do a lot. We have the power. So I would want to leave persons saying, do what you can do to help yourself and those around you. Set good examples for your family members. Set good examples for your children.
Children.
And so you can, if you don't think you have enough information and you don't want to go to your doctor to get it, there is Google. There are good sites to go on. American Diabetes Association, NHS, CDC, there are a number of those medical sites geared towards the public that you can understand little tips in terms of eating, in terms of exercising, in terms of relaxing, in terms of just emotional and spiritual health that can get you to a state of well-being. That's what we're all about, a state of
Right.
well-being. We have to
Right.
be a healthy society, right? To really make any changes, you know, basically to our communities and to those around us and those that we impact. I can be found many places. I think my main office is at Meridian Medical Specialists, where I
Say
work
that again, you broke up a little bit. Just say that again because you broke up a little bit.
Meridian Medical Specialists on Phoenix Avenue. Um, so that's my,
And we have a number?
and the number is 634-5142. That's the main number there, right?
Say that again.
Six
I think
three
you
four
said at the gym.
5142.
Did you say 6?
634-5142.
Okay. Okay.
And yes, as I said, there are a number of societies. I mean, you know, how to get into them is really, you would have to really, like, say, for example, the Lupus Foundation may have a website, so you may want to search these various websites to see, you know, say, for example, Lupus Foundation Jamaica, Diabetes Association Jamaica, and get in touch with these persons and get further information on, you know, what's happening and how the public can benefit.
We have one more question. Shireen is asking, he says, once you go on pressure pills, do you got to live on them, or once your numbers are good, you can stop?
Right. I'm glad that she asked that question because you know, I'll say to patients when they come to me, are you hypertensive? And they will say, no, doc. And then I say, are you on any medication? And they say, oh, and they name a pressure tablet. And I say, but you must be hypertensive. They say, oh, no, doctor gave me because my pressure was high the other day, but it come down, so let's stop. No. So once you're hypertensive, you should be on medication indefinitely. As I said, only if it is that your hypertension is driven by your weight and you've lost weight and you're managing your diet in such a way that so through exercise, diet, and all of those lifestyle things, you get your numbers down. So managing your stress and so on. But you would have to maintain those areas to keep.
I don't think I could come off without mentioning the men, because I know it's a big issue sometimes for the men, because a lot of the hypertension medication, I understand, let them suffer from erectile dysfunction. So what would you say to the males out there who are having hypertension and would like to manage their diabetes with their hypertension? Well, I don't want to say without the medication, but is it okay to try another medication if that,
Right.
or that is just generally the medication?
So
All hypertension medication affects your erectile functions?
right. So yes, there are some groups of or classes of hypertensive drugs that can affect erectile function, put it that way. So it can cause erectile dysfunction or affect your libido. However, there are a number of newer classes of drugs which don't cause this or don't cause it to the extent that other classes do. So we have quite a good armamentarium of drugs that we can use effectively for hypertensive males. Because I tell you, it's a real, real issue. Men will tell you that they prefer to have a stroke than not be able to have sex.
I know that's a general feeling. I'm telling you.
A
That's
lot of
why I brought it up.
Yeah, and they end up in a hospital with a massive stroke and heart attack, and they're not taking them. They have severe hypertension, and they're not taking the drugs because it make the thing don't not working properly. So yes,
Right.
and diabetes as well. Remember, diabetes is associated with erectile dysfunction by itself.
Okay.
So certainly treating diabetes is important and keeping your numbers good.
So you would just say to them, well, if you don't really want to go there, then focus on the healthy lifestyle.
Well, some of them need more than the healthy lifestyle because it depends on how severe your hypertension. Some of them definitely need medication, but there are drugs, there are classes of drugs which do not cause that side effect. So
Okay.
just discuss with your healthcare provider because we can provide options for you, but try not to just decide that I'm not going to take this drug, it is affecting me in this way, and just not going to the doctor until you present in an emergency crisis.
Mhm. Okay. So Peter says thanks very much. He really enjoyed tonight. He gained a lot of information, and Peter, so did I, to be honest. Who's this dog giving joke? Ava Daly says, and then their wives, girlfriends, mothers, And grannies have to become their
There you
nurses.
go. It's so right, true. And the wives sometimes are so frustrated. Doctor, yeah, they're going to the
Yes.
person, and it's a stress.
It is a stress. It is a stress. So we have to help them in the kitchen first, if as best as possible. We
As
help them with the food. I mean, if it's hereditary, then we can't do not much more about it. But as Doc says, there are various different medications that can help that doesn't cause that. So, Dr. Karen Phillips, I just want to say thank you, thank you, thank you. I mean, you came on at such short notice. I really appreciate this. I mean, hypertension and diabetes and high cholesterol are killers,
Yep.
and very prevalent in Jamaica. Like every other person I know is on some form of hypertension medication.
The
Or
population, third of persons in
sorry,
Jamaica.
I didn't hear that. You broke up.
30% of the population in Jamaica are hypertensive.
30%.
They're
That's
over,
1/3.
yeah, almost a
My
third.
goodness.
Yeah, and diabetes about 12% with type 2 diabetes. Yeah. So significant numbers of persons. So, I talk about 12 out of every 100, 30 out of every 100. It's a lot.
Yes. Well, folks, you heard the information. You know what you have to do. As Doc said very early in the program, your health is your responsibility. It is up to you to ensure that you maintain excellent health. Doc, so grateful. Friends, this is our last evening for the season. We are at the end of season 2. We will be back in September, more than likely the first Monday in September. Yes, Calvin, your health is your wealth. You're welcome, Rose. I really appreciate you joining. Friends, I want to encourage you to go on my YouTube page, subscribe. There are 60, I need to count them. There are over 60 programs with nothing but information about health, wealth, um, diet, exercise, sex, penis health, vaginal health, relationship, lupus. I mean, there's so many different programs. We have several other things though. I think I want to tackle maybe next season. I want to tackle diabetes. Not diabetes. I want to tackle Alzheimer's because we haven't had a conversation about that. I want to tackle sleep apnea. I'm going to tackle hearing impairment with Dr. Beavers. We were scheduled for this week, but she had some emergency. So when we come back in September, we want to tackle that as well.
We should tackle COVID as well.
We did. And we had Professor, oh my goodness, no, I have so many guests, my brain confused, I can't remember. Professor, oh Lord, if you ever see me, he would be so ashamed of me. I forgot his name. Figaro, Professor Figaro. I had him because he's my client. Okay. So I was able to hold him and have him on my program because he's also very busy. So we have had very, very interesting programs, lots of information. So you can just visit. Some of them are long, yes, but you can watch them in installment. Because really and truly, yes, they are very informative. Sometimes I try to keep the programs, to an hour or a little less than an hour, not little over the hour, but really and truly the information is so much. Definitely. And when you get the experts like you who are so busy, you don't want to, let you go without getting out all the information at that time. So it's best you watch it. You watch 20 minutes and you come back and you watch another 20 minutes and get in all the information rather than I have all these special people and don't get all the information. So I want to say, spend some time during the break. Watch some of the programs. It's at www.youtube.com/The Totally Male. And as I said, we're taking August off and we'll be back the first Monday in September. Enjoy your summer. COVID still a keep. We're on lockdown again. So people, I'm asking, wear your mask, wash your hands, sanitize, stay safe. COVID still keeping. Everybody's, it's called all hands on deck. We don't want to lose not even one more person to COVID. And as Doc was saying earlier, it's not just, you have the COVID. A lot of people are traumatized after COVID. A lot of people have after effects of COVID. I mean, as she said, it's a monster. And we have been hearing this, but some people don't believe. We have the experts here telling you it's real. It's real, it's real, it's real, it's real, it's real. Please take care of yourself. Yes, Calvin, over 60, awesome. Hearty congratulations, Boss Lizzie. Yes, over 60 programs, absolutely. Stress management is also a great topic. Yes, I will do one on that. Dental health. No, we haven't had dental health. We had dental health. We had dental health with Dr. Heather Lawson. So you can watch dental health. It was very informative as well, because also on that program was where I even discussed sleep apnea, because what was one of the questions that she asked me when she was doing, when she was going through my whole assessment. And she also said, I think you have sleep apnea. You need to check it out. So, through dental practice, you learn a lot of things as well. Awesome. Okay. That was awesome. Dr. Karen drapes me up. Bad. you drape up normal. She said drape up all the time. She drape you up bad. Oh boy. Oh yes,
no, nobody can drape up normal.
Well, Norma, you have her in your corner, because you have her at arm's length. So you shouldn't have no excuse at all. Yes, man. All right. So thank you. Good night. Have a fantastic week. Have an excellent summer. And see you again, hopefully, school a keep in September, where we can go back to face-to-face school. We are hoping that happens. So have a fantastic summer. See you again first Monday in September with lots more information. Bless you, Dr. Karen Phillips. Really appreciate you joining me. And I will send you over a copy, and so that you can share it on your page. Thank you. Okay. Good night, everyone. See you. Bless you.
Okay, bye.
All right, bye.